Hello, Pain fam, and welcome back for another episode of the Modern Pain Podcast. I'm excited this week to share a conversation with someone who's had a big impact on my journey. Steve George is a physical therapist turned researcher who has helped develop modern models of understanding manual therapy mechanisms of effect. Steve is going to share his similar journey and struggles with traditional manual therapy theory. We discuss some of the criticisms he's faced when challenging this traditional theory. We get into the role of the ritual in manual therapy and how it often is not given credit for the outcomes of manual therapy treatment. We also get into the status of stratified care after some recent studies have challenged its utility in clinical practice. Lastly, we discuss AI and its possible applications in the physical therapy world. It was great talking with Steve, and I can't wait to hear what you all think about the episode. My only ask is that you consider sharing this podcast with a colleague to better help us change the world of pain care. Enjoy the episode.
This is the Modern Pain Podcast with Mark Cardula.
Welcome to the podcast, Steve.
Thank you. Thanks for having me.
You know, I really appreciate you spending some time. I know you're busy over there at Duke doing a lot of great things on the research front. I was talking with you before we had on the podcast. I had met indirectly Steve I was going through Evidence in Motion's fellowship. Gosh, this was about 11 years ago. And I was in the midst of my existential crisis that a lot of folks in the manual therapy profession and manual therapy kind of intervention scheme kind of get through, where I just didn't know where the complexity of what I was trying to really figure out what I thought was going to be through my hands and more complexity of technique and different things. And then Steve with Joel Bielowski taught a How Manual Therapy Works course. And some of us who went through that course at the time still reflect back as that being a big stimulus and a big point for us to really have an aha moment of, okay, there's a lot more to manual therapy than what's happening at the tissue level underneath our fingers, and why maybe discriminating some of these like fine dysfunctions, maybe that isn't the answer. And maybe manual therapy can still be effective, but there's a lot more to it than that. So I'm always eternally thankful to Steve for that. But we'll talk into that. But I'd like, Steve, a lot of folks have heard of you, but I'd love if you could introduce yourself to the audience, a little bit of your background, and maybe even how manual therapy was part of that journey.
Sure. And thanks again for having me. And I'm, glad that course was helpful. It's always interesting, when you do something and kind of shoot it out into space, which EIM was one of the early adopters of, remote learning. So it's nice to know it landed at least on a few people, probably mostly the stuff Joel taught, but I'll take credit for it. So as by way of introduction, I'm trained clinically as a physical therapist. I did work for about 7 years full time in various practice settings. I kind of settled into outpatient orthopedics, and all my practice was in Pittsburgh at the University of Pittsburgh Medical System. That's actually interestingly where I crossed paths with Joel. You already mentioned he and I were on the same sports medicine team. We also were on the same softball team. So and I did some of my master's training with Joel, which was heavily influenced with manual therapy at that time. Dr. Erhard, also known as Dr. E, was at Pitt, and he was doing a lot of instruction. So I was kind of at that point able to go to a weekend course and then do right away what we learned that weekend in my practice. So I definitely started off with a very similar background of, there's these 30 techniques I learned over the weekend. I better become proficient in all of them. And, that was kind of in the air. So I transitioned from, practice career to research career. And that part of that transition was moving to the University of Florida and doing a postdoctoral research fellowship. And that was interesting because I was moving from a very heavy PT rehab community to a pain research community. And, I was very fortunate to make that transition. I always tell people this was before anyone thought studying pain for your career was, a slam dunk or an important part. The opioid crisis wasn't apparent yet. This is early 2000s. I moved to Florida in 2002. And I remember a lot of people just saying, oh, that's interesting. I didn't even know there was this pain science or pain research. And I got to work with some of the leaders in the field at the time, and they're still the leaders now. People like Mike Robinson, who was a clinical psychologist, and Roger Fillingham, and Don Price was there, who was a neuroscientist, and really, really influential people in pain research. Roland Stodd is a rheumatologist, and notice I'm saying what their kind of clinical or their training was, because none of them were PTs. So it was this really unique opportunity to bring a physical therapist perspective to a very, very established pain research group. And one of the things, that kind of naturally kind of bubbled to the surface was, well, what's going on with manual therapy then from a pain, research perspective? And Joel's paper that, kind of outlined an updated model of manual therapy was really the result of us, meaning people like Joel and I and other PTs, trying to communicate what we thought manual therapy did to a completely different audience. And that paper was developed for selfish purposes. It was to get us, his dissertation committee, on the same ground, basically. Little did we know that a lot of other people, I think, like you said, we're at this stage where, what is really going on. So this paper, and I don't want to call it a throwaway, but it, we sent it for review, and it got reviewed, and it got published. And, about 3 or 4 years later, all of a sudden people were just very interested in that, in that model. And I think it's a good example of kind of, probably the manual therapy crowd had focused a lot on clinical training. I would dare I say a lot of the communication was probably one way, this is how you do it, and this is what you should be feeling. And, and this was the first time where we had been kind of put on an island, and now we're trying to tell, this leading neuroscientist and these psychologists what's going on. And they basically didn't believe that it was all, that interface. And they helped us to expand into, and really thinking, what's going on peripherally, what's going on centrally, what does that movement of the joint really do? If it's not fixing something, what is it really doing? So that's kind of where we got to the point. And then, when we were doing the thing with evidence in motion, basically it was us getting a chance to practice explaining to physical therapists that model, because we had, now we're in the reverse problem where we could explain it to pain researchers. But for some PTs, that was blasphemy. We were basically, I don't know if you remember, but the initial thing that everybody trains on was like a box. And it was like stimulus, a stimulus either to the muscle, the joint, or the nerve. And it turns out, that's not an underestimation of how, specific can people be. I think people can be a little more specific than that, but it's a good way to think of it. It's like, I'm applying this stimulus manually. I have a target tissue in mind. And, but then there's all going to be all these other things that potentially happen. And maybe it does matter how I talk to the person about this. Maybe it's, I'm not a surgeon. The person's not anesthetized, and I'm not going in there and doing my thing and then leaving. The way I'm doing it, their perception of it, their mood that day, all of those things can impact. So that, that's a little bit of expanded version of what was going on in Florida. But really what was happening is I was becoming part of the pain research community. And then, and very thankful for people like Kathleen Sluka, who really was a physical therapist who I think in the US was one of the first people in that space. And she was very welcoming with my work, the early work that was kind of getting my sea legs. And I was also very lucky that the people at Florida introduced me to, the IASP, the International Association for Study Pain, and the American Pain Society at the time, which is now the United States Association for the Study of Pain. So, was starting to get indoctrinated in what pain research was. And then you fast forward 10 years later, to the IOM report on the blueprint for pain relief. And now everybody's admitting this is a chronic pain problem. And then the same people who were patting me on the head and saying, oh, that's cute, you're studying pain, were like, oh, wow, that was such great foresight of yours. And it really wasn't. I was just curious about it. But it was a right time, right place situation for me. So And then, I worked with some great colleagues. Joel, we've mentioned Joel a couple of times. He gets a lot of airtime, so I'm going to have to make sure, I get some royalties from him. And Mark Bishop, were some of the other PTs, and Jason Benechik. You said you wanted to talk about stratified care. And Trevor Lentz, who's someone who works with at Duke. We just had a really nice group of mostly physical therapists that were interested in their own questions and moving these along. So sorry if I got a little bit, stuck on the manual therapy, but you primed me. So I stayed there a little bit.
Yeah, no, that's we'll stay there a little bit longer because I think there's some things that maybe unpack a little bit. With that publication and kind of you guys discussing, a lot more than just tissue level type effects. And I definitely would agree. It's, a stimulus that we can try to be somewhat targeted as much as we can be, but that really went against maybe the thinking at the time. It was probably a little bit, maybe even controversial for some systems that were still very entrenched in the very specific. I'm wondering, did you face any significant blowback or criticisms for that work? I mean, obviously, all research, gets a little bit of some constructive criticisms. I'm just curious what your experience was as you were kind of introducing us to the manual therapy community, and what kind of the response was.
I think it was there's probably three categories. One was people like you who were like, this makes sense, and almost a liberating feeling, like, I don't have to have all these elaborate stories that, I know maybe have a biomechanical basis, but, geez, they seem like tall tales, and looking back on them that, this goes this way, this rotates this way, and all of that. And I kind of also joke that I always had a hard time with those when I was doing my manual therapy training. So maybe this is just my, frustration, the result of my frustration. But, I struggled with some of those concepts because they kind of assumed everything was happening in a vacuum, like at that segment. And as we know, that's not how it happened. So there was a group that I think, like me, kind of found this was liberating. There's, of course, a group that ignores it because, they're just plowing ahead. It's like, hey, I got to treat 15 patients a day. That's nice. You published something. I'm not interested. And then there was a group that, and no one contacted me directly, but I did hear, we at Gainesville, we're not too far from one of the centers of manual therapy training. And I did hear, through other people that there were some comments made that, this isn't representative of what we're doing. And I do think it does threaten the training model because it indirectly suggests you don't need a ton of, really focused specific training to be effective at manual therapy. And I think, the data kind of supports that to the model's credit. So I kind of think of it as three, different approaches. I do think through the test of time, I think that paper was published in 2008 and they asked us to do an update about 5 or 6 years ago. And when we looked at it, largely we thought, yeah, we can update this, but we don't have to, this is not a going back to the drawing board type of moment. This is a chance to refine. We talked about the different zones because I think that helps people think about it clinically. The first one I think was a little more mechanistic because of who we were talking to. It was also done before there was as many fMRI studies as there are now in pain, so there were some things we could update and maybe be a little more specific of the brain regions that were active and things like that. But largely, it stood up. And I think that's what has happened is probably more people have seen this as an opportunity to feel unshackled a little bit. And this is, like you said, excuse me, not to disparage manual therapy at all. It just moves it into a different management model and the way that you can apply it and the way you can use it, to benefit people, which is the ultimate goal, right? The ultimate goal isn't for the provider to have 78 different ways, they can move the joint. The ultimate goal is to say, I think I'm going to do this. I think it'll give us opportunities for you to be more active later. And I think that's the best thing for you to have long-term pain relief.
No, it was interesting just to see, I think that, seeing some of the reactions just in my clinical world and folks that I've seen practice, there was kind of and I might even got a little bit, this is why manual therapy is not, and obviously there was manual therapy sucks and all these different things that were going on online. And people took it so far to that, hey, we don't even need to do manual therapy. It's not worthwhile, but you bring up some good points. Like it just gives us, manual therapy can still be helpful. We just need to consider the wider context of what's driving some of these outcomes. And again, if it's part of a journey to get someone to active self-management and things, it can definitely still be a valued part of it. And especially if patients have found positive experiences and have positive expectations and things, there's nothing. Yeah.
It's short-term pain modulation. It's an opportunity for that. And I don't, I think that there is the danger of, overutilizing it, but I also don't think that means you take it off the board. If someone comes in and they're in a lot of pain, and they're an obvious candidate, for a good chunk of these people, they're going to feel a lot better if I do a thrust technique. So why would I consciously step back and say, they got to figure this out, or we got to do something more active? I mean, for me, it's always been that's a good way, and it also helps to build the therapeutic alliance, and I think helps to, like you said. Now we've built some trust, and now it can lead into some other strategies that we know probably are better use for long term. You don't have to come into clinic to receive. There's some ways to use that to move forward.
Now, this is a big question, and of course, you wrote entire papers and did a boatload of research on this. So I'm asking you to summarize something that's a bit complex, but I'm wondering if you can kind of discuss where you feel those kind of the mechanisms, maybe the zones of effect of manual therapy, and kind of your view on kind of what's driving some of the change. Obviously, we don't have the perfect ability to perfectly quantify that, but I would love to hear your kind of thoughts on kind of summarizing that.
I mean, I think. And a lot of this is driven by the experiments that we've done. I think one of the things that we saw that was really interesting, but also frustrating, and Joel did these studies following his dissertation, was we were consistently seeing differences in manual therapy and placebo kind of at the peripheral level. So we would do some measures of pain sensitivity, and the manual therapy, the real manual therapy, there's a debate, even what is a placebo for manual therapy. We don't need to get into that. But basically, we were using techniques that you would see in a textbook, and then we were using techniques that were much closer just to kind of like hands-on. And, we would see larger changes in the pain sensitivity that were, a lot of people thought were more mediated at the spinal cord level. So we used some of the temporal summation. I don't want to use too much jargon, but and it was really interesting because there was a couple studies where we just, there was a difference, and it looked like that input was doing something, very locally. But then, we were either smart or dumb enough to also do the clinical pain ratings, and guess what? When we did the clinical pain ratings, the placebo and the manual therapy were much closer together. So I think that helps us to understand a couple things. One, it's, there probably is a difference between the two. So yes, the folks who say it's just, I could do anything, no, there are some differences between, active techniques and just touching your hands, at least at the level where we're measuring with pain sensitivity. Where those folks become a little more correct is now if I'm measuring the pain outcomes, we will see more similarities. And for that opened up this channel of there's probably multiple avenues for people to improve. And I think one of the large ones is that, the expectation that you've received treatment, and it's not like that's the only thing you're going to do. And all of the activities after that, even without that kind of local inhibition, there's all those other pathways in the cortical that are being activated. So, I think of it as there's this kind of local potential for hypoalgesia, pain reduction, whatever you want to call it. We've also seen, and others have seen, you can probably increase that, with instructional sets or providing some positive input. But that alone, doesn't push you ahead. You still need to have other things that are going on that engage, those different zones. And I think, the way we communicate with people is really important. One of the studies that we did as part of Joel's dissertation progression was using different instructional sets. And one was a positive, one was a neutral, and one was a negative. And we couldn't do that in clinic. These were with healthy volunteers, but we've seen the same responses in healthy and people with pain. So this was a study ethically that would be hard to do in a clinic because you can't randomize someone to get you can, but the IRB will have ethical concerns and you'll have to have debriefing. So, we're like, we'll just study this in healthy people. And it was really interesting because almost all of our studies show that short-term pain relief, except for the people who got the negative expectation set. So it shows that even that local part can be, overridden by the other, the cortical centers. And if you change someone's expectations that, we're not sure if this is going to, in fact, we think it might make your pain worse. That is going to affect the way the pain is perceived.
And it so resonates just as far as the experience you have in clinic. I remember just coming up as a manual therapy trainer or trainee, I should say, and having mentors who, God, I felt like I did the technique the freaking same way. Like mechanically, I delivered it very similar, yet got diametrically different results. And then I, stepping back and then looking at the 10,000 foot view, and how I look at like a lot of, very good manual therapy clinicians, they're masters of the ritual of this thing. They can portray it. What are your thoughts on the whole ritualistic components to it?
Well, I think it's important, but I think it also probably led those folks to overestimate the effects of manual therapy because like you said, and again, I'm not meaning to like, I learned from them. I learned the techniques, but like you said, it was almost like they had like the professional wrestler mystique, some of them in the old days where they would come in, to do a weekend training, and take their cape off and it was just very, like you said, the ritual part of it. And it's like, give me your hardest person. And, and then they would, so I think it was, they were supremely confident. They were better skilled too. I'm not saying that my skill level was anywhere close to theirs. But I think the combination of those two, if I'm betting on it, I think the big driver was probably their overall confidence. And, one of the things when we were doing that expectation study is we realized those people who've been doing it for so long, they never use even a neutral instructional set. They're telling, this is exactly what you need. This is misaligned with this. You're so lucky you came to see me because I picked this up. And you're even luckier because I know exactly what to do to fix it. And we're going to do it now. I'll take off my cape. I'm exaggerating a little bit, cue the fireworks, let's get ready to rumble. Then it goes. But, I'm obviously, hopefully for for the subscribers, playing this up a little bit. But it's to make the point that you just did that they leaned into that ritual. And I wonder if it was because the reinforcement was they knew that's going to be part of getting a strong response. Now contrast it with you and I, who are the poor, we're like shaking and we're like, I hope this works. And the person's kind of like, is this your first time doing it? And it's like, well, do I tell them the truth or do I do, so that, those two presentations are very different.
Yeah, no, completely agree. It and again, it liberates a lot of the young trainees of like, that it's some sort of, and I know for me, I falsely went on this, I just got to go on the Jedi pursuit, man. I got to figure this thing out through my fingertips, and maybe I just can't discriminate those millimeters. And then stepping back, your research and others say, hey, it still has a place. Again, we're not throwing things out, but it's just, we need to pump the brakes on, some of the mechanisms and some of the theorizing of what we can do with our hands, but putting it in a perspective that if it moves a person in a positive direction, it can be part of the journey. But yeah, the wrestling analogy, I like it. I'm going to have to use that.
Very early clinical experiences before I was going to, before I even knew I was going to do research, went to a Maitland course. And they used to bring people in, very well-known people into Pitt, and they would train everyone instead of sending people out. So they were like, you know what, it's more efficient. Let's bring in the best, and then we'll have weekend courses. So I was exposed to a lot. And I don't even remember the instructor. It's not important. Just that they were all in on Maitland. And we spent the first 4 hours doing grade 1 mobilizations. And the only feedback this person would give was, grade 1 is strong enough to bend the knees of a fly. And I heard that enough. And I finally just said, what does that mean? Tell me, how hard is that? Is it a big fly? Is it a little fly? And he looked at me and he said, it's just what you need to bend the knees of a fly. And that's the perfect answer for Jedi, right? Because now I'm supposed to go and think about this. But I had spent 4 hours doing grade 1 mobilizations, which sure as hell didn't seem much different than the graded 1 mobilizations. And I just left. I just couldn't take it anymore. But that's, like you said, that for some people, they're going to, and I don't think it's their fault. I think, here's this person, they're revered, they're brought in. But I had a bad reaction to that. And again, that might have been something. But I guess I was hoping for a little more guidance than bending the knees of a fly. And when I asked for it as a learner and didn't get it, it was dissatisfying.
Yeah, I've had similar sour taste in my mouth from some of the explanatory models, begging for depth and some more logical explanatory models, and sometimes it just fallen flat in that effect. But again, I think, we're looking big picture. We're seeing some of the contextual ritualistics things, which aren't necessarily bad. It's just recognize they're part of the gig, and it's part of why your mentors and things are having these great outcomes. Doesn't mean you're deficient as a clinician. I mean, I was at the point where I was ready to quit. I just can't do this thing. I can't just have bending flies' knees and making things magically improve. It made no sense to me. And
I will say, Dr. Erhard, he to me was a kind of a hybrid. He was fluent in all of the prior language, but he understood a new kind of approach was needed, because even he, when we would talk to him, he would kind of give us the traditional, and then he would kind of give his little spin on it. So that definitely, we could see his mind was kind of in both worlds. And Joel and I have talked about that it was nice that he was at least open-minded enough to let us peek behind the curtain every now and then. And even for him to say, I know we taught you 7 techniques to do the upper cervical, but these are the 2 that I really mostly do. And I can't tell you, why why we don't need the other 5. So I do think he was definitely in that transition zone where, and like I said, kind of grateful for that. But he also knew, he knew the traditional part too, because that's how he was trained, and he was revered. So he was in that kind of wrestling persona for some people. For us, he was just Dr. E. I mean, we had everyday access to him, and not that we abused that, but we had a lot of conversations with him, in clinics and things like that. He would let you. He had a spine clinic. If you had a patient you're having trouble with, he would let you, because it was the same health system, refer the patient to him, and then you could come and watch and talk to him about it. And that was pretty cool, for someone 2 years out of PT school to be able to do that.
Yeah, no, that's a, awesome experience, one that mentorship piece like that. And then having somebody to help translate the past to the present, okay, this is what we're saying in the past, and let's translate to what science is saying, and kind of being able to, give you a good perspective on both maybe the traditional view and maybe, him being on the probably forefront of seeing, okay, we got to look bigger picture. I need to kind of update my explanatory models of what's going on here. So yeah, great to have folks like that in your world clinically to maybe get your feet a little bit more stable on the ground as it kind of constantly gets questioned and different things as you're trying to figure things out. But I'd like to switch gears a little bit, because we had talked before about touching upon stratified care. There was the initial, start back in Jonathan Hill's group, where there was some pretty promising results of the start back tool, where we would go from low to medium to high risk and stratify care based on, those ratings on the start back, where high levels of distress, the high categorization where there's, we needed psychology or behavioral health services along with PT and things. And then, low risk folks would, maybe just need traditional PT on its own. And then the research trying to replicate it. I know you were part of Dan Rohn's study that recently came out in JAMA. You published a commentary in Pain, and we'll link all this stuff in the show notes so you all can take a peek at those. But I'm wondering maybe if you can kind of give us a little bit of a rundown of kind of the journey of stratified care from where it started to maybe where it's at now with some of these recent studies and some of your commentaries on it.
So, stratified care, I was first introduced to it. And again, right place, right time theme permeates. Now, need something to do in my spare time other than manual therapy. So I was, I guess, lucky enough to review the first start back paper that was the prognostic paper. And I had been using the fear avoidance beliefs questionnaire and actually published a trial in 2008 where we were looking at people with high and low beliefs and whether they did better with graded exposure. And one of the people reviewing the trial said, you really should be using the start back tool. And, our response was, that's great. It wasn't available when we were planning the trial. So then I got a chance to review the paper. And it was a very, I can see why it took off even in reviewing that paper. So one of the things I thought is we need to study this, and had another PT who was doing his PhD with me, Jason Banachak, who, by the way, came in and really wanted to do some manual therapy stuff. But he was also getting an MPH. So he and I sat down one day and just talked, and I said, if you're getting an MPH, you might want to think a little more, broadly about what your dissertation is. Here's this new tool that's going to be published. What do you think? So he, over at Brooks in Jacksonville, started collecting some of the first start back data in the US, as best I can tell. So we looked at it, and sure enough, it had good prognostic abilities. So we started thinking, like, how do we apply this in treatment? And we did an early trial over at Brooks where we trained some PTs and then monitored their patient outcomes. And lo and behold, the PTs that we trained in risk stratified care, their patients did have better outcomes, especially for disability. So that matched the start back trial. So we're like, maybe this is the way to go. Now, what has happened since is, I was lucky enough to be part of the target trial team. That trial did not find results. There was another trial in the US, the MATCH trial, that had part of the Keel team to help training, and it didn't find any positive results. Then the Danes, there was a CIS study in in Denmark's health system, didn't find differences. And Dan, all along, Dan had been running Dan Rohn, as you mentioned, he's the lead of that. He brought in Jason and I to do the training for the military study. And the military study I was really interested in because the military has a lot of resources for behavioral health. So it's not like when you do these in the private setting where, you have to get a referral. They have a lot of resources. And Dan, part of the study was making sure the high risk folks had, good access to those. And then, that study ended up being null. The commentary was a stratified care study in whiplash, and it was null. So yeah. I think my thoughts on stratified care have changed a little bit, but maybe instead of changing, maybe they've been distilled where prognostically, definitely you'll see differences based on high, medium, low. And that's kind of the shooting fish in the barrel part. We've known that for a long time, but that tool is a very concise and effective way to see that stratification. The response to the treatment, we have seen a few proof of concepts, but, the ability to propagate that is challenging. And then it boils down to, and what I tried to talk about in the commentary, it really boils down to the training burden. It's surprisingly hard for health systems sometimes to get the right patient to the right person at the right time. So, you have this, what sounds simple on paper of like, well, I'm screening someone at primary care. The high risk people need to go to PTs who've received additional training to deliver psychologically informed care. Well, for a health, for the same kind of universe that created a COVID vaccine in record time, that seems like we should be able to do that. It's surprisingly challenging when you get in there and start doing these, especially pragmatic trials. And then what do you do when half the therapists you train change jobs in a year, and then what do you do when the other half of the therapists are saying, you don't need to do this stuff? I don't know that I would say it's dead, but I do think the efficacy, effectiveness, contrast in risk stratified care is larger than you see in some other things. And I think it's due to the challenges of, like I said, it's a multi-step. And then the intervention you apply, it's not an easy intervention to apply. And oh, by the way, the high risk patients also, are more likely not to show these are not the types of patients that are really giddy to get their 18 PT visits in. So, and rightfully so. I mean, these are people that the health system hasn't helped. They have pain, their beliefs about pain. I tried to get, for the people who are listening, this probably isn't an incentive to read the commentary, but trust me, it's a lot more concise, the thoughts. But I do think it is, if we really like that model, it has to be done in a way where it's fully embraced. And I think that's why the first trial worked. I mean, Jonathan, it was in an integrated health system, very strong support, an excellent training model, so I think that's been harder to get in the follow-up trials. And maybe they underestimated, people like me underestimated what that training burden was going to be like. I will say in Dan's trial, the other thing is, well, are you even applying the treatment? In Dan's trial, we did not see differences in the primary endpoints, but there was some evidence in his trial that the risk stratified care was applied because we did see some decreases in psychologic distress. So we didn't have that in the target trial. So, it did seem like we were getting some of the treatments to them. And then the other thing I wonder, and I mentioned this briefly in the commentary, maybe unbeknownst to us, maybe usual care is getting better. Maybe people are paying attention to these guidelines. The Start Back trial was published in 2011. We're 12 years later. The American College of Physicians, really the guidelines that changed things were published in 2009. Like when I say change things, they were the ones who kind of really leaned into, frontline non-pharma and stuff like that. And it's been about 15 years. Maybe usual care is getting better. And maybe that's something as researchers, we've always kind of been able to assume usual care is not good, but maybe people are paying attention to those practice guidelines. And that's something, as I was thinking about and I don't know how to test that, but, that could be the other possibility.
Yeah, no, good points. You bring up the training burden. We had Peter O'Sullivan on and Peter Kent of the Restore Back trial a few episodes ago, and so they have a very intense training. I mean, 40 hours, I think it was, which is impressive. But it'll be interesting to see. Obviously, they're more geared towards helping that medium to high risk group maybe navigate things a little bit more effectively. And then, can we? Because I agree. I think there's a lot of systemic barriers to where you have a system where it's not that nice, neat identification and get to. I used to practice at the Mayo Clinic, and it's a amazing place. Some of the amazing world's best biomedical innovations have happened there, and we're grateful for it. But it is a very long, winding path of ologists you can see there at Mayo, where it's not maybe this nice, and with a lot of differing opinions and differing labels on what's going on. All probably pathologizing the same forest, but with their unique tree look at it. But yeah, so you bring up some good points on that for sure. I think.
Yeah, wouldn't it be interesting if like CFT works in Australia and risk stratified care works in the UK, and maybe some of these things are like much more system dependent and the willingness, to accept training. for the Target trial, we wanted to train longer, but the funding agency wanted it to be pragmatic. So they wanted it to fit in a traditional 1-day CEU course. If Pete was on here, Pete O'Sullivan, he'd say that's completely insufficient. And I would say you're probably right, but we don't have the models in the US to give people, 40 hours of training if they're, and I'm not saying one is right or wrong, but I'm just saying that, that's an issue.
Yeah. Just the reality of what we're facing. They had, mentored, they had sessions like you had with Dr. Eve where they could have trouble with patients, and they had, direct supervision of folks watching their encounters and helping them in the midst of it, which I told Peter that I want to be in that camp, that trial, just for the sheer learning opportunity, let alone obviously being better able to help patients with some of this stuff. So yeah, there are definite challenges, and I agree. It would be fascinating to see what are the approaches that might best fit the system versus maybe thinking one approach works across all systems, because we're seeing that challenge and it's not really materializing itself.
And each of those countries have different cultures too, and thoughts, and I think for things like back pain, that may matter. I mean, that's kind of, it's hard sometimes to fathom because people think, oh, back pain in Australian, but there may be some differences that, we are just kind of becoming aware of.
No, 100%. I mean, I just remember reading some of the studies of when Western medicine was introduced to some of these populations, indigenous or populations where, I think it was Aboriginal. If I remember when I first read some of the research and how back pain got way worse once Western medicine things came about. So yeah, there's definitive cultural components to that experience, and how we define it and how we kind of look at it culturally is definitely an impact for sure. I wanted to talk a little bit. I really enjoyed your lecture in 2017, the Maley lecture. Really was a good one to kind of talk about some of it was pain management, the roadmap to revolution, and we'll link it in the show notes. You can watch it. I think it's on YouTube, and then there's a dictation of it online as well. I'm wondering your thoughts, maybe kind of looking at that roadmap that you were talking about in 2017, and you've been a big part of, Physio's journey, improving our journey and maybe better, help informing our journey as we're better trying to understand pain and where does it fit. And as we've talked today, within the context of a manual therapy intervention, how does this all kind of come together? I'm curious if you can maybe discuss kind of that, your roadmap view and where you think we're at and where you'd like to see us go. And maybe if you think we're following a good roadmap at the moment.
Thanks. I think, it'll be interesting to see as that ages, if it, if it stands up. But I've had a few people say, they still use at least parts of it. The tattoo artist always seems to be an interesting one. But, I think my view of the roadmap is a little different. So that lecture and looking back was really kind of the bookends. I mentioned, I'm introduced to the Pain Research Committee in 2002, and then 2016, 17, get a chance to do this lecture. And that was kind of the bookends of my pain research time at Florida, because then I moved up to Duke shortly after that. And I think it encapsulates, like you said, that during that time, there was a change in PTs, physios, from being interested in it to, participating in it, to now it was like the expectation is we know, we want to be a legitimate kind of player in this pain management space, especially the non-pharma. So, my view on the roadmap now is, and it parallels what we talked about with stratified care. There's enough content out there. There's enough of people that have models. Pain neuroscience education really took off. Like you said, the CFT approach. What I see kind of lacking when we go and we try to do like embedded pragmatic trials is it still is not trickled down, to everyday practice in a way that, if I randomly did a survey of 100 people who received PT today, I think it's probably better than it would have been 10 years ago with some of the things, but I don't think it's where like the APTA markets, how we do with pain. So in a way, it's encouraging because I think it's moving in the right direction. But I do think, as a researcher, constantly reminded of the limited reach of our work. That's why it's nice to come and talk to people, who are willing to help disseminate this information in different ways and forms. Because as a researcher, I'm not trained to think of this, disseminating my information the same way you are. So it's nice, to be able to talk to someone who has an understanding of what we've done, but also has a much broader audience and reach than I, ever could have. So I think, part of the next part of that roadmap would be, I think, to be more maybe strategic about some of those plans. I do get a little frustrated that as physios, especially in the US, we tend to reinvent the wheel. I do get a little frustrated that there's not more understanding and appreciation and partnership with organizations like ISP. Like, why do we have to recreate our own pain toolkits when they've been available for 10 years? And we're developed by international physios. Like, why does the US have to develop their own, and kits? I worry sometimes too that we're recreating some of the problems in the past by creating some of our own lingo around pain instead of, again, kind of embracing the international approaches to things. But overall, I think, and I do think the academic programs have done a good job. A lot of them have found room in their curricula to have more dedicated education. I don't see that happening as much like with physicians and other. So I do think, this, when I talk to DPT students now, which isn't as much as I did when in Florida, like before they're going out to practice, they know a lot about pain science. And I'd like to think that's an advantage. Where it becomes a problem is when they bump into their clinical mentor who maybe doesn't. And we know that unfortunately the clinical mentoring tends to override the didactics. So, I think giving the new trainees the confidence that, this is relatively new material and, not all CIs are going to keep up, not all the clinical instructors are going to keep up on things. So I think, I think some progress has been made. I think it would be fun to revisit that maybe in 10 years and see like where we need to go. One of my goals, which hasn't happened, is also to get in the US the way like the APTA thinks about things is in its academies. They used to be sections. And I really think there are things that should cut across, and pain is one of them, because ortho, the Ortho Academy, really, they put a lot of time and resources into pain but that kind of creates the impression that only orthopedic patients have pain, which we know is just wrong. And B, that, that it's not something that's in the wheelhouse of every physical therapist. So, one of my goals would be, let's not just think of pain as like a special interest group. Like, why isn't pain considered in cardiovascular? Do people have chest pain? Yes. Does it sometimes indicate, a serious problem? Yes. But it also, a lot of times, just, there's a lot of interesting things with visceral pain and cardiac pain. And, I have an emergency room colleague, and that would be a really fascinating research project, is helping people understand, when chest pain is truly benign. PTs could have a role in that, neuro pain, people understand stroke, spinal cord injury. So you can see it kind of cutting across, but we tend to partition it. And I've had conversations with people like, how can on one hand we say choose first, and then when we look structurally at our, professional society, that thing we're choosing first is the special interest group of one academy. Like, how is that installing, how is that kind of showing that our structure reflects that choose first part? So maybe there'll be some opportunities to align that a little bit better.
Yeah, no, I completely agree. I think pain is not an ortho section only or ortho academy only issue. Having my wife's a cardiovascular specialist or CCS in through the APTA, and definitely deals with some pain and different things in that realm. And we're trying to, at Midwestern University, trying to incorporate it throughout curriculum as far as, it's because it's not just a unique, I think, neuro, geriatric, there's just so many, applications, and it exists across. It doesn't just pain doesn't coordinate itself off to one body section
And the way the APTA would suggest we handle that now is each of those components have like a SIG, and each of them would have their own little meetings, and they would talk. But really it needs to be, going more horizontal than just straight that way. Those are the things I think about, reflecting on the Melee lecture, which was, an incredible opportunity. I had a great team help me put it together. As you could hopefully tell, we had some fun with it, but, it also, it's resonated with a lot of people, and we've received positive feedback from that. And that's, for a lot of people, that's still, for me, if you're looking for one-stop shopping, that's not a bad place to go.
Yeah, it's packed full of good resources and a good talk. And like I said, we'll link it in the show notes so people can watch it. One last question. As a researcher and with your experience with all the great things you've been talking about so far on the podcast today, what are the biggest questions you think that linger out there? I know we spoke to some about manual therapy, stratified care. Maybe those are the questions that we haven't discussed yet that you're thinking about, but what questions do you think we need to ask and hopefully answer to better help, pain care, be it physio or maybe across health systems?
Yeah, I think, one of the things each kind of field has, their holy grail questions. And the one that is really intriguing to me is the acute to chronic pain transition. I think I've been part of a group that has helped to understand like what the psychological part of that is, but it's not the only part. So I'm really interested to see, what's going on, and how can we take what we know with the psychologic, and now do we add like what are going to be the biologic contributors, what are going to be the social determinant contributors, and can we really put that together? And one of our colleagues here at Duke, Adam Good, he's been working a lot on that acute to chronic transition, and really, I think, has some interesting directions that maybe will go looking at some of the biologic parts of it, the biomarkers and things. And that's really an area I'm intrigued because, like I said, I've spent a lot of my time in that psychologic realm. So I think, that is one area that I'm really interested in. And then I think, can we get to the point where we can truly kind of individualize either someone's prognosis or, their pain profile for like, what are things you will respond, like, what are the things you're likely to respond well to? What are the things that maybe you should avoid? Right now we kind of do that by trial and error, but it would be nice to have, and people have done that in nutrition. They've done that in exercise. People take a lot of different, the elite athletes now, they get a blood test, they see what their lactate, there's a lot of things, whereas in the past it was, and I feel like that's where we are still in pain a little bit, where, you find out when you've exercised too much, when you exercise too much.
So what are your thoughts on AI possibly contributing to this? I've talked to other clinicians and they're talking, could those models help us maybe gather and make sense of all these complex data points? My concern is like, you're never going to substitute the unique human relationship in those non-specific contextuals that an AI interface may not be able to provide to somebody, Agora. But what are your thoughts on maybe do you think that's do you see that being helpful at all? Or is it something you've considered or seen considered?
I think it'll be helpful, but maybe not in the ways that people think. I've been exposed to AI more on a conceptual level. There's a lot of interest, obviously, everywhere. Duke has a strong AI health science team, and they, there's the folks that are working on the math part of it, and that part I don't pretend to understand. There's a small part of me that was like, I was decent in math in high school. It's like, it would be fun to go back, but then it's like, no, it wouldn't. But conceptually, AI is best when it can get a lot of convergence, right? So when, as an example, we're working with an AI health fellow she's developing like deep learning for measuring hip knee angle pre and post arthroplasty. So that would be something that right now, the surgeons have to do. Excuse me, we have an arthroplasty team and she's part of it. And this would be a big help, and it probably would be more accurate. It was something that could be done, which would allow the surgeons to either spend more time with the patients, see more, The nice thing about that, though, is it's a closed system, a lot of convergence. When I see some of the things that we've been talking about, and this kind of links to my high variability, like AI is not going to be as good with that, because it's going to have trouble with the learning, because it would not like that. When I take a 47 degrees Celsius temperature threshold, and put it on your arm, which is what we've done tons of times. My understanding, and at least in this generation of AI, is that would be trained to expect a certain response. Well, I know I'm going to get 0 to 100 ratings because I've done it and other people have done it. And that's one of the things, by the way, that is the same in Australia, Europe, UK, and the US, is that variability in that pain rating. I don't know, conceptually, I don't think that's the best fit for AI right now. So, if it's AI at looking at like automating scoring of questionnaires, getting standard information and consolidating a profile, do I think AI would be great for red flag screening? Yeah, I do, because I think you can ask the same set of questions. There's probably a certain set that indicates this person needs, to be considered at higher risk. But do I think AI is going to say, well, this person needs 4 sessions of manual therapy followed, I think it actually can tell you that, but like you said, I don't think that's it. That's not how it's trained, because it's going to be so divergent. So that's, my long way of saying, I think this generation of AI, the learning that's occurring, is going to be best suited for, things that converge. And that's how would be my guidance. So for clinicians that are looking to jump on it, and things like note writing, yeah, I would always want to have a section that I can personalize it. But yeah, there's parts of the note that probably voice to text, the AI would knock it out and it would be better note than I would write. But A, I'm going to make sure I always read it, and B, I want to have some areas that, like you said, when it's outside of what the algorithm thinks, that I have the opportunity to update that.
The APTA just had, I think, the Health Innovation Summit. One of our clinicians at Midwestern just went to it, and the AI was a big topic of discussion, especially on the documentation front, which I will freely admit it is not the most enjoyed part of my day. And most clinicians, I don't think it's the most enjoyed part of their day. I'm a compliant documenter, but begrudgingly with all the...
Yeah. I mean, you'd be an accountant, right? If that was the most, there are people that enjoy that documentation part, but most of them, I don't think, drift towards PT as a profession.
Yeah, that it would not be their chosen craft for sure. Well, Steve, I wanted to thank you again for your time today. I really appreciate it. And also just thank you for all the work you've been doing and helping us better understand this thing. So
let's not wait 10 years to interface again. Let's make sure we cross paths.
Absolutely. We'll have to, I know I'll be at some conferences. I know you're always at the APTA conferences, so we'll have to grab a coffee or something and chat.
Yeah, February in Boston, coffee sounds good. It won't be warm, that's for sure. The coffee will be warm. The weather may not be warm.
Yeah, that's always I wish the APTA would stay south, but I get it. We got to go up to spread our wings and let other parts of the country get a little bit of the pub. But I sure don't mind when it's in San Diego and other places. Although last year was brutal weather, but what are you going to do? For those of you listening, we'd love if you could subscribe on your podcast listening vendor. And also if you're watching on YouTube, if you could subscribe there, that'll help us get the information out to more people. But until next time, we'll talk to you next episode.